why IVF cycles in patients with poor prognosis should be individualized. In our practice, we see many patients who are older and oftentimes, 42, 43, 44, 45, and even older, who are choosing to still go through IVF, even though, their prognosis is rather poor. But sometimes they need to do that just to sort of reassure themselves that they've tried everything before they move on to donor egg or something like that. And surprisingly, we've been, successful in a number of these people, and we've had a lot of experience in taking care of people in this age group. One of the things that we recognized a few years ago is that many of our older patients, when we had them on standard sorts of stimulations, would end up with a number of atretic follicles. And we wanted to try to understand that better and understand where that's coming from. And one of the things we began to realize is that if we could individualize the individual stimulation cycles and plan when to trigger, we could do better. And we'll take you through some of that today and what our thinking is on that. This is our faculty disclosure, which is necessary. Nothing that we're talking about today has really anything to do directly with any of these disclosures. So today I've got three basic objectives. One is to just describe a little bit about the role of the follicle and the supporting cumulus granulosa cells with the oocyte. Also to understand better how varying the timing of the ovulation trigger may help us to get fewer atretic eggs and more competent oocytes, and see what so far what our experience has been in evaluating the utility of those kinds of changes. So here's a good old picture of the oocyte with its cumulus granulosa cells and the mural granulosa cells. You can see that there's an intimate relationship between the cumulus cells and the oocyte. There are slightly different functions for the mural cells than for the cumulus cells. So the mural cells are giving off the estrogen, AMH, inhibins, and those things that we can use to actually monitor a cycle, also producing various growth factors. The cumulus cells that I want to focus on today are really involved in some bidirectional signaling and support of the oocyte. So the oocyte is not really running its own metabolism. It's getting its support from those cumulus cells, its energy support. There's signaling going back and forth that signal the maturation or the arrest of maturation of the oocyte. So this is a really important concept. And we're not going to go into detail about these various things, except you can see that they're interacting with the oocyte in various ways. So the overall concept here is that if we can make more competent follicles, or keep the follicles at maximum competence, we can get better oocytes and ultimately get better competent embryos as well, which should result in better pregnancy rates. So in this slide, we're all aware that producing an oocyte is a concert of activities, many different things going on, but we can't really see the egg before we take it out. We can't see what it's doing. So how to monitor what it's doing as we're going through the ovulation induction. And we use the signals that we have available to us, which is the follicle size and the production of estradiol, and of course, possibly the arrival of production of some progesterone. Now, progesterone represent luteinization, and there's been a lot of discussion in our field about luteinization, the effect of progesterone on endometrium, decreasing implantation rates. But what we're focused on now is if you let the follicle go too long and it begins to luteinize too soon, that's a signal you're starting to lose that cumulative cell support. And that's what we're focusing on. So we began looking at this about 6-7 years ago, and our embryologist, Yonggang Wu, published this paper in which we looked at the luteinization of granulosa cells and the effect of changing the timing of the retrieval to see how those signals would go. And we divided our patients into 3 groups. So we had donors who were kind of the control group for all this, who expect to have normal sorts of response. We had patients that were older, and then patients that were sort of intermediate age. I think the cutoff there was around 38 or something like that. And again, what we did in the standard retrieval for people like donors is like 18 to 20 something for the retrieval. And then for early retrieval, in this case, we're looking at follicles that were max around 16 millimeters. This is what we found on the molecular assessment. You can kind of use the donors to see what you hope to see, what healthy sort of molecular picture is for this. So this is aromatase, FSH receptors, LH receptors, and progesterone receptors. So an increase in LH and progesterone receptors kind of represents that early luteinization. You can see here that the early retrieval versus the normal retrieval, the early retrieval is moving more in the direction of the healthy donor. So these people were, more or less in the same age group as they're being compared here. And you can see that the aromatase was better, FSH receptors were better, that there were fewer LH receptors and in the early retrieval, and fewer progesterone receptors. So those were all signs of moving in a better direction. And here we've got the comparison of the early retrieval to a normal retrieval in terms of what we were able to see. You can see that one of the costs of this is that we did get more, as you would expect, more immature oocytes, but we also got fewer atretic oocytes, and the number of good embryos that we got was significantly better, and the percentage of pregnancies was much improved. So we got, again, this is a very high risk, unfavorable group, but we had 11 out of 71 pregnancies compared to just the 7 out of 91. So we looked at that as a benefit. And actually, let me just, I don't know how to go back, but we had a larger percentage ending up in continuing pregnancies as well. So that's how we're dealing with our older patients who already had some evidence of diminished ovarian reserve. But we also began looking at our younger patients who had some evidence of diminished ovarian reserve as well. So we looked at that in another paper, and this is what Dr. Gleicher coined the term of a highly individualized egg retrieval, which is called AIR. And the improved IVF results that we get in this case by avoiding the premature luteinization. So here you can see we tried 3 different levels of retrieval. This is very early, so this is like 13.5 to 15.5 millimeters. This is 16 to 18, which is what we were calling early retrieval before. And this is a more normal 18.5 to 20.5, and these comparisons. And it went faster than I wanted to go. How do I go backwards? Oh, over there. Okay, so you can see that over here at the end of the day, the best actually ongoing pregnancy rate was in the early retrieval compared to the standard retrieval, and actually going too early didn't help us very much either. So in this case, for this sort of older age group, we did better at 16 to 18. And then these are younger people, people in their 30s who had evidence of diminished ovarian reserve. And again, with the earlier retrieval, we had better pregnancy rates compared to the standard retrieval. So we've kind of incorporated this into our practice. And in terms of different age groups, we are generally triggering our younger patients at a standard sort of 18 to 20 lead follicle. And our next older patients at 16 to 18, which is what we've been talking about, 42 to 44, or even a little earlier. And I'll tell you, we've had actually pretty good response with people 44, 45, 46, 47, getting mature follicles and good embryos, even when they're as early as 12 millimeters. The oldest patient who's achieved a pregnancy with her own eggs in our practice was 47, actually 2 weeks before her 48th birthday at the time that she conceived. And she was retrieved at 12 millimeters and did end up with a healthy little girl. So sort of in summary, the whole focus here is to try to better understand follicle competence as a way of making a competent ovary and better embryos. One of the costs of all this is that when you do early retrieval, more of the oocytes may end up being immature, and some of those that appear mature may not have fully achieved competence. And so we're trying to understand that better. Future directions are to try to better understand what we can do to take advantage of this bidirectional communication, and find ways to try to help maintain that competence before you take the eggs out, maybe changing the nature of the stimulation in some way. Try to see what we can do to preserve competence after early retrieval of those that might come up being immature. We've been looking at various co-cultures, various supplements to the media, see what we can do if we leave, if we don't strip the eggs right away and let them maintain their connection with the cumulus, and then try to add stuff to the media to try to make the cumulus perform better. And all those investigations are still ongoing, and we're hopeful to be able to tell you more in the future. So thank you for your attention. This is a picture of CHR and all of our staff and affiliated folks. And I appreciate the opportunity to have been able to share this with you.